So I would like for the ones who are here on the screen to understand mostly just before going to the diagnosis. I mean, it's do you think that the cultural differences they also influence how patients refer angina? And I give you one example. I work in an hospital that drains from different areas. I mean, there is a very affluent area where my British patients tell me, "Oh, I don't have angina, I have a tightness." Then it drains from other areas where I get a lot of Southeastern Asians or backgrounds where they say, "Oh, I don't have chest pain, I don't have angina, I have something like gas in my sternum." Then I get patients from Caribbean origin, and they say, "Oh, I got this crushing chest pain." So, and that is typical. So, do you believe that when we ask about angina, first of all, patients understand, and secondly, do you feel that there is a different word in different cultures that may express better the angina? I mean, and I would like to go around on how I see you on my screen, and starting on top on the bottom on the top left with and then going around. So I put you on. I put you, Dr. Stoyanov. I put you on the spot. So, what do you think?
Oh yeah, I fully agree. We have different regions in Bulgaria, and they're using totally different words for. And your explanation was perfectly on the spot, and that's why our let's say our work is like art that we should to understand different cultures, different regions, different people, and to recognize what they really complain, and with their the language, it's yeah, with different words. I cannot say better than you. But I fully agree. I fully agree.
So can I ask now, Dr. Lipa? Last time we discussed about the diagnosis. So it's what's your experience?
Well, I completely agree with you guys. Pain itself is one of the biggest, the most subjective things. You cannot say to the patients, "You do not have pain." If he says that he has pain, he has pain. Even if he doesn't, so we must believe him. And at the personal perspective, subjective perspective, it's really, really important. So we can have all the diagrams and all the guidelines, but in the end, it's still the patient that we talk to, and different perspectives. It's up to the physician actually to know local specialties, as you pointed out from London, when you have different cultural backgrounds. Well, fortunately, Slovenians, we don't have many different nationalities living in Slovenia. So pretty much we get patients that usually come with a specific problem that's pretty much the same. But having different nationalities coming to the hospital, there's a lot to think about, and especially from a physician point of view, to approach to those patients in the correct way to get the best answers that give us the direction where to go with diagnostics.
Yeah, Professor Özkan, thank you. Professor Özkan, what about Turkish patients? How do they refer to angina? I mean, do you see differences?
Thank you, and this is an excellent point. In Turkey, we do have same difficulties. I completed my mandatory government service in the eastern part of Turkey, and the ladies, elderly ladies, presented with always chest pain. The chest pain was almost a standard, the standard profile. I was even not asking whether they had a chest pain. I was trying to figure out in a different way whether this is an angina or not. So when I moved back to the west part of the Turkey, they generally presented with not angina, shortness of breath, easy fatigue, Even yesterday, I had a patient with me in the cath lab. I generally, while I'm doing a PCI, when I inflate the balloon, I'm always saying to the patient that you may feel chest tightness or chest pain, and I test this hypothesis yesterday, and the lady, after inflated the balloon, the lady did not feel anything, any chest pain. Right after, I had a patient from a different part of the country, from eastern part. Just after inflation, the patient started chest pain. I mean, there are mainly two things. First, as we stated, the pain is a very subjective issue. And on the other hand, they may feel stress as chest pain or high blood pressure. As a physician, it is very difficult to differentiate or rely on their pain profile to make a clinical decision in understanding their ischemic burden, because angina is a different issue, ischemia is a different issue. We have to take into clinical profile with their social background into account while we are assessing their angina. But bottom line, we have to trust them.
Yeah, no, thank you. Very wise words. Now, what about Azerbaijan? I mean, you're close, but let's see whether there's big variations.
Actually, I can say that I think that there is some, evidences of maybe IQ or education level, because sometimes I face that they can't express their, for example, complaints, and I realized that especially among women, they have shortness of breath, whereas male, they have more typical angina symptoms. And also in diabetic patients, I face that they don't have any angina or any other pain, or maybe feel, but actually they don't have angina, but they have more ischemia and more obstructive coronary artery diseases.
Yeah. Okay, thank you. Now we're going towards the end. We've got a few minutes, but I would like just to have another quick round. I mean, try to think that you're not in your cath lab. Try to think that you are the general cardiologist in your country. Now, what would you say is the first step approach for patients with that presents with chest pain, angina, whatever we call it? And would you start treatment before or after the test? I mean, if you're convinced that chest pain, that symptoms is typical, would you start before the test or you wait? So let's go back in circle once again. And we start from Dr. Stoyanov again.
Thank you very much. I have outpatient clinic also, and as I showed, I'm starting in front the optimal medical treatment. And in our country, the queue for the non-invasive stress test is quite long, and my patients, they're waiting really long. That's why I'm starting the medication, the treatment really upfront before the test, and I'm waiting and I'm following the patient before the test. I usually use scintigraphic tests, but my patient, they're waiting about month or month and a half for this examination, and I have a time to see the effect of the treatment.
Okay, excellent. Now we go now to Slovenia and Dr. Lipa. and then we'll move close. And because I understand that there's Professor Kovacevic that wants to talk, but a camera doesn't work. So Dr. Lipa first.
Yeah, I agree. I completely agree. Thanks again. I agree. I think it's not acceptable to leave those patients without medication. There's really very high probability. I mean, we're all clinical physicians and we have to decide and then just to confirm or discontinue. I mean, statin and maybe aspirin and some anti-ischemia drugs are not as harmful as it would be leaving those patients without any medications.
Absolutely. No, thank you. So we will, Professor Oz, can we wait just 1 second and we'll ask Professor Kovacevic to, yes.
Hello to everyone.
We don't have the pleasure to see you, but it's at least it's a pleasure to hear you.
Yeah, excuse me, my camera doesn't work, so I do apologize once more. So thank you all to all speakers, especially to Dr. Stoyanov about the great cases. I just want to make first short comment about angina in general. In my country, in Bosnia and in Balkan as a region, we have a rather common profile of the patients. They do complain a lot about some chest pain or something that we maybe call angina. So it is really extremely hard to differentiate that angina from some other pains. So we do need a lot more tests. So I am really amazed about Bulgaria that you showed up the data that you have 59 cath labs, if I saw it correctly, that work very hard, but only 2 places where you can do any physiology about these coronaries. So it's really hard. I would love to ask you and to see how do you manage in everyday practice to differentiate about some 70% stenosis of LAD, like Dr. Isgender showed us, and they did PCI procedure, as I understood well, but we actually do not know if that lesion is really significant or if that lesion really causes angina. We have to go with optimal medical therapy, of course, but there is so many patients with such intermediate lesions where you cannot say it is cause of angina. So please tell me, how do you do it in everyday practice? And the second comment, maybe from Bulgaria and Azerbaijan, about the optimal medical therapy and about lipid lowering therapy. What is your routine practice and what is actually covered by insurance companies regarding these new therapies, PCSK9 inhibitors or something else? Is it reimbursed or the patients have to pay the full price of those medications? Thank you very much.
No, thank you. So I mean, very quick questions because then we have to very quick answers from both of you, and because then we have to continue with Professor Ozkan.
Okay, I'll do my best. Yeah, that's why I showed this data, because it's a really strange situation. In our cath lab, we are paying from our institution for FFR and physiology, but we are exception for the country. Our colleagues, they decided case by case to stand or not to stand. That's why we have a really let's say struggle with the national insurance front, because I'm a part of the board of our Society of Interventional Cardiology, and we spent 3 years of letters to have this reimbursement for FFR, and now this is the case. We can use FFR, but we will have a big problems to teach the others to use this physiology assessment. But we will see. But you're perfectly right. That's a really strange situation. But this is because the reimbursement politician problem. It's a politic of the country to full pay for the stents and angiograms, and not to spend nothing or almost nothing for a stress test and for the physiology, for example. And yeah, that's my answer. Okay.
Yeah. So, and Dr. Isgender, a quick answer, then we go to Professor Ozkan before concluding.
First of all, I would like thank you for excellent question. And I think that actually about, as you mentioned before, I think individualized approach is crucial because every, it can be different scenarios, and we can apply different diagnostic tools and also treatment as well, I think. And nowadays, for example, in Azerbaijan, our insurance system provide with a lot of diagnostic tools, a lot of, I mean, governmental or non-governmental medical centers. And but about treatment, I can accentuate that it's also depends on situation. If I think if patient has, for example, more concomitant diseases or other things, I think yes, we should apply some treatment therapies like maybe calcium channel blockers, beta blockers, ivabradine, trimetazidine, like such kind of thing. But I think we should also reveal the how can I say, the origin of the problem, because sometimes every second, every minute, it can be gold for our patient, and I think that we should follow that we should yes, initiate medical treatment as first step, and also we should review the problem to solve this, in order to solve this problem in next step. And also about I can say that, for example, now I prefer using combination therapy, and it's not only about dyslipidemia. I think that if patient has arterial hypertension, also we should initiate combination therapy. And nowadays, actually, in Azerbaijan, Citizimab and statins are available, and inclisiran will be available soon as well.
Thank you. Thank you. Now we go to Professor Özkan before concluding, and we'll have the possibility of hearing from you on the 13th of April on the multifactorial origin of angina. But I would like to have also your opinion on how to approach patients, whether you start treatment before. What is the approach that is in general in Turkey for patients with angina, with symptoms?
Thank you. First of all, if I am sure that this is a typical angina or high likely of ischemia, the patient has ischemia, I would definitely start medication, optimal medical treatment. But it depends if the patient has comorbid factors such as arterial hypertension, dyslipidemia, diabetes. So we should start, I think, anti-ischemic medication, because this is bottom line a gold standard treatment. However, if the patient has no risk factors such as high blood pressure, dyslipidemia, or strong family history, I would like to see test results first, and then we'll proceed. There are a common sense in Turkey. I can see in Turkish cardiologists, they may prefer to start at least aspirin and metoprolol basically before even sending to stress tests. Maybe from the perspective of low, I mean, maybe they hesitate if the patient has ischemia, at least we should start some medication. But my decision, I think we should see first preliminary test, and then we can start. If the patient has unstable angina, for sure we don't discuss it. But if the patient has stable angina, based on the risk factors, we can make a decision.
Very good. Thank you. So we are now 5 minutes past what our time, and I mean, I wish to thank you all for this discussion. It's been really nice. I wish to thank the two speakers for the very interesting cases and for the discussion. And we look forward to the next meeting. Is on the 13th of April. It will be the multifactorial origin of angina, individualized treatments and local practices with Professor Stojkovic and Professor Orzen. So, thank you all, and have a very good rest of your day, and see you all soon.
Bye.
See you. Bye.
Bye.
Thanks.
Bye.
Yes, sir.